knowledge is power. So what are we going to do today? First, we're going to talk about ethical principles of medicine management. We have to know our rights. We have to have a foundation before we embark on something that can have a lot of risk. We'll discuss the 4 basic principles that must accompany medicine management. And finally, we'll do an overview of the 3 behavior areas that typically can be sought for medicine management from a psychiatrist, and some things of what could be prescribed. And then finally, we'll end with a Q&A session. And remember, I'm not your children's physician, but I will do my best to answer any questions I can. And if I don't know, I'll be forthcoming with that and hopefully guide you to some sources that can give you more answers. So let's first talk about diagnosis under ethics, because diagnosis begets treatment. I'm sure you guys are all familiar with the DSM-5 criteria for autism. Children who have white Sutton or persons with white Sutton, there's lots of variations on how they can present, what challenges or deficits they may have as related to the DSM-5. An umbrella view or big picture view of autism, the primary deficit is in social emotional reciprocity. It's not that they aren't social or they don't love people, it's just they struggle with, how do we go about this, navigating with other humans, regulating their emotions. They also have restricted repetitive behaviors or interests. Sometimes this is codified as rigidity or inflexibility. They can have really special interests and really go all in on certain things. And then finally, there's the other criteria that make it more precise, as far as these symptoms must come during the developmental period. They must cause clinically significant impairment or distress in multiple areas of life. And these aren't better explained by perhaps another medical diagnosis or challenge. And another note is that we can put that it's associated with a known genetic condition or environmental factor. In this specific population, this would be white Sutton. So again, diagnosis begets treatment, meaning medication management. And we look to data to guide treatment. There's problem with studies in this and that. First of all, just the big diagnosis of autism. Should it really be split apart? One of my favorite quotes I heard at a conference was from Roy Grinker, who also has a child on the autism spectrum. He said, a diagnosis, autism, so broad that it includes people who are non-speaking and require intensive support, as well as people who work at the highest levels of academia, government, and technology, whose mild autistic features help them succeed professionally. It's really hard to look at the literature knowing there's such a broad diversity in that diagnosis. And few studies actually specify the different levels, level 1, 2, or 3, when you're looking at, okay, if this medicine helped persons with autism, was it mainly level 3s? Was it mainly level 1? So that's some problems that we just need to bear in mind when we look at literature and we look at medicines to managing behaviors in persons with autism spectrum. A quick run through of your rights when receiving medicine management. Disclosure. Physicians have the obligation, meaning they must discuss the risks, benefits, side effects, and alternatives, which include no treatment, when receiving psychiatric and medication management. This is informed consent, risks, benefits, side effects, and alternatives. This comes from the legal case Salgo versus Leland, Stanford Junior Board of Trustees, all the way back in 1957. That was the first case that mentioned doctors need to disclose risks. Prior to that, medicine was very paternalistic, meaning doctors said my way or the highway. There are very few patients' rights. patients' rates really started to come online in the late 50s, 60s, and 70s. Another landmark case that really opens up informed consent even further is Canterbury v. Spence in 1972. This codified that you have to discuss the benefits of treatment, side effects, and alternatives. This is known as the informed consent doctrine. You might come across that as you look through, look online. Benefits. So I love this graph or this picture because it really is a take-home visual about nothing ventured, nothing gained. If you're looking for a big benefit, unfortunately, it usually comes with the big risk. Rare in medicine is it that there's hardly any risk and you get a big reward. That kind of just seems like the universe in general, but that's something to bear in mind. We always need to keep in mind, what's the goal of this? What are we looking at? Are we looking to improve their quality of life? What specific area? Is it FDA approved? Now, don't hang your hat on if, goodness sakes, if it's FDA approved. It's not a must. And unfortunately, not a lot of things are FDA approved for right and wrong reasons. And aside on the FDA, this is my little soapbox. The FDA can range from, in all areas of medicine and medications, from very, very harm avoidant to extremely liberal. Ballpark, it can take 20 years from beginning of a drug development to hitting the market. That can be faster or slower depending on the urgency of the clinical scenario. But don't get too caught up if a medicine that's prescribed to your family member isn't FDA approved. And also bear in mind that kids or persons with white Sutton, there's not large randomized controlled trials looking at this. So we just have to have a healthy dose of skepticism and also being open-minded that there's just a lot we don't know. Also know about the FDA, over-the-counters like Tylenol, ibuprofen, some cough syrups, supplements, and herbals. They are not regulated by the FDA. They're not doing studies to see how well they work. They're not looking at side effects. They've got to focus on the more high-stakes prescription medicines. Another ethical part of medicine management is pharmaceutical duty. Companies must update warnings when new safety information arises. Even though they may spend decades researching a drug, new things can crop up as more and more people get it clinically when it comes on the market. For context, bear in mind the FDA was promoting cigarettes. There's the Vioxx and there's Fen-Phen. If you're an elder millennial like me, that those were the big blockbuster drugs, and then they were pulled off the market. Also, who is motivated to find problems? Like it or not, the pharmaceutical industry likes to make money, and perhaps they're not motivated to find what doesn't work in the drug that could cause them a loss of capital or investment in developing a drug. Patient autonomy. The courts increasingly protect the right to know and choose options. You have a right to choose. You can say no. You have a right to bodily autonomy. You'll hear the phrase throughout literature, right to be done with his or her body. You have the right to make decisions without coercion. You don't have to make it that moment in the office. If a patient isn't on board, I'm like, hey, just think about it. There's not a pressing need. Typically, this isn't so on fire that we have to make the decision now. Take your time, do your research. You have the right to refuse treatment. You have the right to make reproductive choices. And these principles are grounded in the United States Constitution. And in most states, I'm licensed in Florida and in Oklahoma, and every state has their own rights. But in most states, parents will be the ultimate decision maker until a person is 18, or if a person has guardianship. A quick aside on guardianship, there's a difference between medical power of attorney and guardianship. They are not the same thing. Power of attorney focuses on medical problems, not mental health and not developmental disabilities. This is in most states. Every state is different, but I strongly advise a guardianship evaluation at 18 to ensure protection of a person's rights and timely access to care. We can't admit a person to an inpatient unit for dangerous behaviors if if they're 18 and up without commitment paperwork, or if their family member has a guardianship. It's just much smoother if they can't make their own decisions to get a guardianship. Last slide about ethics, and then we'll move on. Look at the evidence threshold. Look up the drugs, do your research, ask for second opinions. Is it tested? Is it peer reviewed? What's the rate of error? What are the controls? What are the standards? What's generally accepted? Practice guidelines, they're guidelines, not authoritative, but research is also an exception for these evidence thresholds. So if you're in a research study, all bets are off. It's a new set of ethical principles. You can look this up further. In this case, landmark case, Daubert versus Merrow-Dowell Pharmaceuticals. So I'm sure we're probably having you guys sit in one of two camps right now. You're probably in purple shirt camp. That is, I'm not really excited about this anymore. Or perhaps you're in orange shirt camp. That's like, let's go. I now know my rights. Let's learn more. Generally, I think you'll find you'll be somewhere in the middle, hopefully, at the end of this talk. So now we're going to move to the next objective, lifestyle. Nutrition, exercise or activity, sleep, and media consumption. These four things I, as a practitioner, will ask you about every visit. And if a psychiatrist isn't asking you about these four things, you may consider a second opinion. I'll say this twice. Even the best medicine cannot overcome a lifestyle problem. Even the best medicine cannot overcome a lifestyle problem. So you've got to look at your nutrition. You've got to look at your activity, your sleep, and your media consumption if medicines are going to work. So nutrition. Special needs parent, we struggle with this. We're exhausted all the time. Some may not be, but it can be a struggle for parents with special needs children to eat a healthy diet, especially during Halloween. There's candy everywhere. Keep as much routine as you can within moderation. Use games to make it more fun. Lots of patients play Candyland or Sorry or something where there's a physical game you can put in the center of the table, and they have to take a bite before they can have their turn. That's a great motivator. The less processed food, the better. We've only had processed food as humans for about the last 100 years, when human beings have been around for millennia without processed food. It takes more time, it takes more effort, but there's a lot that we don't know. We don't have long-term data on what all this processed food is doing to our bodies. Stay hydrated. Don't drink your calories. This is a mantra, because we can pack on the pounds, and not in a healthy way, if we're drinking things like sodas or smoothies. Although smoothies may seem great, they can be loaded with just tons of sugar and not a lot of fiber or nutrients. Progress is progress. Don't be too hard on yourself. Be kind on yourself. If you go from your family member eating 5 different types of foods and you get to 6, win. All I'm saying is just be mindful of nutrition and do the best you can. And a great tip I learned from a colleague is a buffet restaurant could be your new favorite restaurant. When you're trying new foods or trying to be healthy, it's a lot of work to prep the veggies or make a nutritious meal. Insert the buffet. They have lots of fresh veggies there already prepped for you, so you don't feel so bad if they don't like it. Worst case scenario, I think every buffet has fried chicken or French fries or ice cream. So you can try the healthy things. And if not, you haven't put too much effort into it. Moving on to the next lifestyle area, activity and exercise. Kiddos and persons with white Sutton, they may have different physical challenges where doing typical exercise or play may be more challenging. Do what you can. Getting outside, in my view as a clinician, counts. There's so many benefits from being outside. Being outside and maybe doing a meditation or just deep breathing. Maybe you can do stretching, or maybe your kiddo can climb to the top of the playground and you have to eye on them that they don't fall. Just do what you can, but be mindful that we've got to get some activity or get outside if medicines are going to work. Sleep. This is another soapbox. I am very diligent about sleep, both in my own life and my family members and in my patients. I will always ask my patients about sleep. Sleep is how our brain resets. You can't expect your car to keep working if you don't do oil changes or if you leave your car running in your driveway all night. Sleep is our rest. It's how our brain resets for the next day. You can look over this graph on what's the recommended amount for kids and adults as we age. For the population we're looking at, typically most people need around 7, 8, 9 hours. If you could get in that, wonderful. Some people are a little lower. Some people need a bit more. Everybody's different. If we're dropping below 7 in a developing person, that's a big concern. That's you should see somebody about it. And then media consumption. You put good things in, you get good things out. Garbage in, garbage out. Media is so prevalent now than just 1 or 2 generations ago. Consider setting screen time limits. I can't expect kids to fall asleep well if there's a tablet in front of their face. Same with adults. If you're scrolling on your phone before bed, I don't expect good sleep. Consider abstaining from social media. Personally, I do not have a Facebook account, TikTok, Instagram, what have you, whatever's out there. I can't keep up with them all. There's so many. Because when my boys get old enough to want social media, we can say mom and dad don't have it. I rarely see people go, oh, I am so glad I have so many social media accounts. I just feel so much more peaceful in my life. Usually the contrary is true. When I encourage patients to take a social media break, or they give it up for Lent, or they give it up instead of maybe a dry January, it's dry social media month. They usually come back at the end of the month going, I feel more peaceful, I feel more connected, I have less anxiety. So consider that, consider these 4 things: nutrition, activity, sleep, and media consumption as we start to talk about medicine. So here we are, let's talk about medicines. Good news, bad news. There are no prescription medicines that are FDA approved for sleep in children. And that's not just children with a developmental disorder or children with white Sutton. This is any kid on the planet. There's no FDA approved prescription medicine. So where does that take us? Okay, so maybe you're in purple shirt or orange shirt camp. Let's look at it further. The most common medicine that comes up, I find in Google searches or patients asking, is melatonin, because it's both available over the counter and prescription. Melatonin is a hormone found in the pineal gland in the back of the brain, and it regulates sleep and core body temperature rhythms. Its production is inhibited by light exposure. So if you're throwing a bunch of light in your eyes, whether by TV, tablet, any type of screen, within 2 hours of bedtime, your pineal gland is going, nope, not doing it. not making melatonin. We're not sleeping anytime soon. And the reason why is our body didn't used to live on electronic rhythms of lights and media. We used to be hunter-gatherers out in the wild where we woke up when the sun went up and we went to sleep when the sun went down. We did make fire as humans, but that isn't as bright and triggering as that blue light from a screen. So that's why media keeps us awake at night. So be mindful, try and wake up when the sun comes up, go to bed when the sun goes down. So back to melatonin, it's immediate and long-acting release, both over the counter and prescription. You can get those either way. It can come as a gummy and also a tablet. Gummies are great, easier to take if people have trouble swallowing pills. In children, the average dose is anywhere from 3 to 6 milligrams. That's 2 years old and up. And then it should be taken between 30 and 60 minutes before bedtime to work. The benefit, the reason why we're looking at it, is that it can increase total sleep time by 50 to 60 minutes, depending on what studies you look at. And it's great for sleep onset, meaning it's great to help you fall asleep. Not so great for helping you stay asleep. Every patient I see for the first time, I ask sleep, trouble falling asleep, staying asleep, or both. And depending where they fall in the falling asleep, staying asleep, or both, it can change what interventions we choose, both for medicine and for lifestyle. So melatonin is great for falling asleep. Side effects, not surprising, drowsiness. It can increase bedwetting because the person is more sedated and drowsy, so they may not be as in touch with cues to wake up and use the bathroom. They can have nightmares. So this is really important, especially in persons with developmental disabilities, because they may have communication challenges where they can't tell you. You can see drowsiness in another person. They're sleepy, they're lethargic, they're not as active as they normally are. You can see bedwetting. That's very objective. You can't see nightmares. Full disclosure, this happened in my son when we were putting him on melatonin. It worked for a while, and then something seemed off. He was having more nighttime awakenings. So it's very hard to discover, especially if your child can't communicate with you as maybe a neurotypical child. So just something to bear in mind. Also, headaches. It's hard for a person with communication challenges to describe what a headache is and feels like. Even neurotypical children have trouble describing what headaches are. Risks of melatonin, both over the counter and prescription. The benefit is not long-term. You can get tolerance, and what may work for a couple months may not work 3 to 6 months down the line. That isn't an end-all be-all. Some children, even kiddos with special needs, can be on melatonin, and it works great for years. Every kid is different. Another question to ask or risk is, are you getting what you paid for? Specifically, what's the quality of the medicine? Over the counters, remember, they're not regulated by the FDA. I encourage patients, if they purchase any type of over-the-counter, whether it's melatonin or something else, where is it made? Canada and the United States have the best manufacturing standards. Things from other countries, they could have heavy metals in them. They could be dirty factories. They may be old or expired, or perhaps the content of the actual active ingredient is not what they say it is. And remember, melatonin is not great for middle of the night awakenings, or sleep maintenance is the term we use. The good news is the cost is relatively affordable over the counter. I don't know different insurance companies on what they pay for. Typically, they don't pay for over the counters for cost savings. Next, clonidine. Clonidine is an alpha-1 agonist. It's primarily known as an antihypertensive or a blood pressure medicine. and it reduces sympathetic outflow. What does that mean? It reduces the fight or flight system in the body. If someone came into this room that everybody's in and dumped a pile of snakes, or if I saw a snake in this room right now, my sympathetic outflow would go through the roof, meaning my heart would race, I'd start sweating, I'd be fearful, my eyes would be dilated, I would be breathing hard, I would hightail it out of this room so fast. That's your sympathetic outflow. And so clonidine reduces that. It can come in different forms: immediate release, extended release. It comes in a patch. As a psychiatrist, I love a good patch because it makes dosing pretty easy. Dosing range, it is very small and it's like razor edge. So it can be from 0.05 to 0.225 milligrams a day. That's also why we love a patch, because you set it and forget it. Benefit, why we prescribe clonidine for sleep: it improves sleep onset and maintenance. So falling asleep and staying asleep. Patches can also be great for persons who don't like swallowing pills. You don't have to worry if you had to split a pill, if you got the dosing right, because it's such a razor edge margin. Patches, you set it and forget it. And for kids who may be tricky, this isn't just developmentally disabled children or white Sutton kids. Any kid can be sneaky. And so you can put that patch on their back and they likely won't be able to get it off. Or you can put on the jammies, the footy jammies backwards, so they can't get their pajamas off to get it. That's a good clinical pearl I love. The backwards jammies have saved many patients and my own kiddos late nights. Side effects: it's a blood pressure agent. Not surprising, you can get lower blood pressure. It can slow the heart rate. That's what it's there to do. It's there to reduce that sympathetic outflow or reduce that fight or flight response that's going on in the body. Typically, kiddos on the autism spectrum tend to have their sympathetic dial turned up a notch compared to average kids. So therein lies the purpose of why we prescribe clonidine. Side effects, irritability. It can make some kids more irritable, dry mouth, and it can suppress REM sleep. REM sleep stands for rapid eye movement. This is the part of sleep where you have vivid dreams and your long-term memory, your hippocampus is storing long-term memories. This is necessary for our brain to refresh and restart for the next day. So if you don't get great REM sleep, it can lead to fatigue, impaired memory, and negative mood. If the medicine, clonidine, is stopped abruptly, you can get a rebound high blood pressure, and you can get rebound REM sleep if it is stopped abruptly, meaning they can have hyper vivid dreams that can be really disruptive and can even make some children scared to fall back asleep if they're that vivid. Another sleep agent, guanfacine, also called Tenex or Intunev. This stimulates the prefrontal cortex through a series of circuits that cause sedation. Again, take home message, it reduces that sympathetic outflow. So that fight or flight you're feeling if a snake's in the room, this helps turn the dial back on that. It only comes in tablet and the dose range is 0.5 to 2 milligrams a day. You don't have to swallow the tablet whole. You can crush it and put it in applesauce or hide it in some taffy or candy. However you can get a person to take it, I'm all for. The benefits, it can be used off-label for sleep disturbances. There's little literature support in this, but also bear in mind, there's not a lot of motivation to study this because it's beyond its patent. If my memory serves, the length of a drug patent in the United States is 17 years. So there's not much money to be made once it goes past that 17 years. So drug companies and for valid reasons, aren't motivated to do a lot of research on it because they're looking for the next drug that may be bigger and better. So just because there's not a lot of literature there doesn't mean it's used commonly. Also, we're going to touch on this a bit later. Guanfacine can help with inattention and hyperactivity. Side effects of guanfacine can have dry mouth in anywhere from 10 to 60% of persons taking it, headache up to 26%, dizziness, and constipation. Similar to clonidine, abrupt stopping of the medicine can cause rebound, high blood pressure, or anxiety. And you have to be mindful if your patient is, or if you are dizzy on the medicine. Dizzy spells can lead to falls, and falls can be quite dangerous and lead to hospital stays. So if you're feeling dizzy, tell your doctor. Another sleep medicine, hydroxyzine. Hydroxyzine is just another form of an antihistamine or an allergy medicine. Antihistamines are the most common non-prescription medication for sleep in the pediatric population, meaning this is what most pediatricians and even psychiatrists are prescribing or recommending people take, since you don't have to have a prescription for some forms. Hydroxyzine is just the prescription type that most psychiatrists prescribe. There's different types. You'll see doxylamine, diphenhydramine, Benadryl over the counter. They're all very similar structurally. It comes in tablet form. Persons can be taking 10 to 50 milligrams a day. Some people space it out through the day. If they're having anxiety, it can be used that way, or they can take it as a single dose for sleep. Benefits: it can actually help kids or persons with bruxism or teeth grinding. It increases sleep depth, or that sleep maintenance, how hard they're sleeping. So it can actually help with sleep maintenance, and it can also help with sleep onset. So it can make you drowsy and maintain that drowsiness throughout the night. It's recommended only for short-term use, but goodness, I can think of so many adults and children that have been on an analog like this for years and years. Just because there's not research doesn't mean it's not going on. You have to have motivation to do research. And again, hydroxyzine is a medicine that's beyond its patent. It's out there. It's in generic form. Side effects, similar to lots of medicines we've talked about: dry mouth, constipation, headache, and drowsiness. Again, I mentioned this, evidence is lacking for long-term use. Some kids can develop tics or increased anxiety, whether you have autism spectrum or not. And remember that autism spectrum symptoms in white Sutton, or in general, remember, autism spectrum is looking at people really high functioning who need minimal supports, to persons who need to support persons to maintain their life. That's all in one diagnosis in the literature. So it's really hard to tease out. Some great resources for sleep. Autism Speaks has a great toolkit with a video on how to optimize environment and routines to promote great sleep. Consider cameras. They can track your kids' sleep or notify you if they have a big enough awakening. Social stories. I love a good social story. Do a social story to teach your child. When it's nighttime, we stay in our bed. We use quiet voices. So many social stories out there. And then if you really want to go on a deep dive, this is a great PDF about all different types of medications that can be used in the autism spectrum population for sleep. So just a reminder, we're going to move on to our next two big areas of medications. And this big risk benefit. Again, if you don't take big risks, you're probably not going to get big benefits. I'm lumping this all together just for simplicity's sake, but stimulants. This is kind of the hot take, hot button medication right now. It can be used for attention and hyperactivity for children with autism spectrum symptoms, that many of them can have that big sympathetic outflow. There's two main areas. There's methylphenidate. These are the Ritalins, the Concertas, the Metadates of the world. And then there's the mixed amphetamine salts, or amphetamine, dextroamphetamine. These are the Adderalls, the Adderall XRs of the world. Methylphenidate, it's a controlled substance, meaning it's a Schedule II. You're only going to get 30-day supply at a time. You may have to do a drug test every 30 days. It can be a lot of work to get a controlled substance, especially with kiddos, depending on what state you live in. Mixed amphetamine salts, or the Adderalls of the world, it also is a controlled substance. You are only going to get 30-day supply at a time. This promotes release of norepinephrine or catecholamines in their presynaptic terminals, meaning methylphenidate just blocks the reuptake. Mixed amphetamine salts promote the release. So how does it work? I touched on that briefly, but basically the whole end game is to have more catecholamines in the synaptic cleft of the neurons to help with the deficits or the problems that children with autism spectrum have with attention and hyperactivity. The brain is one big circuit board, and by a process of excitation and inhibition, children just need more catecholamines to make the circuitry work better. So this is a great picture of how methylphenidate works. It blocks the reuptake of catecholamines in the synaptic cleft. I'm not sure if my mouse works, but the green, these are the catecholamines. These are the things that we need more of to make the brain circuits work. And methylphenidate is the orange. It helps block the reuptake, so more of those catecholamines stay in a synaptic cleft. So this is how mixed amphetamine salts work. This is way too complicated. We're going to do this super fun video that a colleague shared. Now, let's see if it works. No, we're going to try a different way. Josh, you may have to help me on this. Let's see. Sharing your screen share. Let's go. Here we go. Okay, share. We're going to share this one. So this is this really fun TikTok that makes my psychiatrist brain happy. Let me make it full view for you guys, full screen. And I'm going to stop it. Sorry, my husband's trying to call me while I'm giving a talk. Love it. So this is how Adderall works. It helps promote the release of the catecholamines, norepinephrine and dopamine. So here comes the Adderall. It's making those catecholamines go, and then woo, party at the receptors. So bear in mind the Adderall is going, let's release all the catecholamines and have the little sombrero party at the other end of the neurons. Okay, I'll stop now, but we'll go back to the PowerPoint. But I just really wanted to share that because I think it's a lot of fun. Okay, so next slide. How do they work? We talked about that. The whole end game is we need to make the brain circuits work for children with autism spectrum. We need more catecholamines to make it work. And this will improve attention and reduce hyperactivity. And you may be thinking, is this really legal meth? Well, you're not too far off. The top image is the chemical organic structure of methamphetamine, the illicit drug. The bottom structure is Adderall. It really only differs by one methyl group. Up here, this is a carbon. Down here, this is a hydrogen. They're very, very similar, but children with autism spectrum type behaviors have different brains, and we just need to support the brain circuitry as best we can with medicines. And this really does work. The forms you can get stimulants, it can really be a range on the dosing. I'm not going to get into that nitty gritty today, but it can come in lots of different forms because that's how great it works. That's how many different varieties there are out there to meet each kid where they're at. So it can come in capsules, it can come in tablets, chewable tablets, always a win, liquid. And you guys know I love a good patch because it makes it simple, set it and forget it. You don't have to worry if you took the pill or not. You just look, oh, the patch is there. The benefit, this is FDA approved to reduce hyperactivity and inattention, especially in kids in autism spectrum. So it's FDA approved, both the methylphenidate and the mixed amphetamine salts. Now, side effects, nothing ventured, nothing gained. This is the seesaw. GI side effects are really profound. So it can lower appetite, it can lead to weight loss, and it can fall off the growth curve. It can cause insomnia, but if you're having insomnia with the medicine, it just means we're not dosing it right, or the timing isn't right, the dose needs to be reduced. That's a fixable problem. And in some children, it can increase irritability of whether a kid with just pure ADHD or perhaps a kiddo with hyperactivity with increased, that we're looking to dial that back. Risks. Unfortunately, it's not as effective, all stimulants, when compared to neurotypical peers that are being prescribed it for attention or hyperactivity challenges. In children with autism spectrum disorders, their brain circuitry, they unfortunately have more side effects. So this isn't like a do not pass go, do not pursue it. We just have to be more mindful with that population. Again, I'm going to harp on it again, lower appetite, weight loss, and falling off the growth curve. These can be deal breakers for kids because they need to stay on the growth curve. All kids should get a baseline EKG to monitor their rhythm. Although they're generally accepted as safe, it's just a precaution because it can prolong a certain interval in the heart rhythm strip. So it's just prudent to check that. Monitoring. Weights. Stay on the growth curve. They may need an EKG once a year. They need to monitor their weight at least every 2 to 4 weeks when starting the medicine. You also have to watch for a risk of diversion. It's really challenging when you're prescribing a medicine and the family can divert it, or perhaps a different family member or a babysitter steals the medicine. These are things you have to lock up. You don't tell other people your kiddo is on this. The only people who should know are the need to know people. And how do we know it's working? How are we watching? Data. Get it from as many sources as you can. Take inventories from their school teachers. Get data from their ABA clinic or their ABA program. Watch their progress on their IEP. Have they started making more progress? What are their grades looking like? So that's how we see if it's working or not. Other medicines I'm kind of going to skip over just for the sake of time, but I mentioned previously clonidine and guanfacine can also be helpful. They're alpha agonists. They're lowering that sympathetic outflow. So if you are feeling more on the calm, the less hyped up, the less sympathetic outflow, it makes more sense that you'll be able to pay better attention and not be so hyperactive. Again, I'm going to speed through this, but this is a great study on how helpful guanfacine can be helpful for hyperactivity, impulsivity, and distractibility in children with autism spectrum. Visuals. If your kiddo is having problems with attention, make visuals specific to them. This is one that has a chart for everything a kiddo needs to do to get ready in the morning. Big fan of visuals. Again, risk benefits. We're going to move on to probably what you've been waiting to hear, or kind of the hot key item, which is aggression and irritability. These are the atypical antipsychotics. Risperdal, it was, if my history knowledge is correct, the first medicine FDA approved for autism spectrum, specifically aggression and irritability. How do they work? Block reuptake of dopamine and serotonin. These are atypical antipsychotics. Yes, they are used in persons with schizophrenia or augmenting depression treatment in persons with major depression. They come in a dose range for Risperdal or risperidone, 0.25 to usually 1 milligram in persons age 5 and up. Rarely would you go above 2 milligrams in the population we're talking about today. It comes in tablet and liquid form. Liquid form is pretty expensive. Pharmaceutical companies and insurance companies don't like liquids. They're costly. And the benefit, again, FDA approved for tantrums, aggression, and self-injury. It takes a lot for the FDA, who tends to be very harm avoidant and cautious in mental health medicines. It takes a lot to get the FDA approval. So it's something to consider. Side effects. So nothing ventured, nothing gained. Sedation. This is a big side effect. 40 to 45% can feel sedated. On the converse, some people can have insomnia depending when it's dosed. Anxiety is a side effect, fatigue, and notably increased appetite. These medicines unfortunately cause significant weight gain, and that's why I talked about nutrition and activity, because those will come into play if a person is taking this medicine. Risks, anticholinergic side effects. You're starting to probably catch on to a pattern: dry mouth, constipation, dizziness, blurred vision. This is just how the brain circuitry is. When we're working on these types of behaviors, it's going to come with this cluster of type of side effects. Metabolic syndrome. This is very specific to atypical antipsychotics. High blood sugar, elevated cholesterol and lipids, weight gain. Other more scary or rare side effects: drug-induced leukopenia or neutropenia, meaning your blood counts drop. It can lower the seizure threshold, meaning it can make it more likely your child can have a seizure. And it can also elevate prolactin. What does elevated prolactin mean? It means that children can develop galactorrhea, or milk coming out of their breast tissue. Both men and women have breast tissue. It becomes more developed when women go through puberty, but milk can leak from nipples when on this medicine with elevated prolactin. Can also cause gynecomastia, meaning the breast tissue enlarges. And for women who are in puberty, it can cause amenorrhea or even stop their periods, because the elevated prolactin can be that profound. So elevated prolactin is also something that we monitor when any person is on risperidone, not just kids, not just autism spectrum, anyone. An EKG should be done before you start treatment. It can prolong the QT interval in a heart rhythm strip. It's quite rare to have QT prolongation, but it's prudent as a start point, just so we know if things change in the future. You got to monitor weight closely, and you got to monitor diet closely. Consider labs. Oh, it says abs. I wish it came with abs, but you should monitor the laboratories, like your blood sugar, your cholesterol, your lipids, every 3 to 6 months on this medicine. And you should also monitor for very severe and rare side effects, such as neuroleptic malignant syndrome, tardive dyskinesia, and extrapyramidal symptoms. Those 3 tend to happen when you're on very high doses. For children and white Sutton kids that we're looking at, it shouldn't even approach that. You should be looking at very, very small dosage. Start low, go slow. And finally, the last medicine we'll talk about today before the Q&A is Abilify, or aripiprazole. I'm going to say Abilify because it's easier to say. How does Abilify work? It's a partial agonist at dopamine and serotonin receptors. It also antagonizes or stops serotonin at other receptors. So it does a lot of different things. Take home message, dopamine. It gives more dopamine where the circuitry is needed in the brain. How does it come? It comes in a tablet. It comes in oral disintegrating tablet, which is really great, an oral film, oral solution, and even an extended release injectable. A really wide variety of ways that you can get Abilify, which is really great. You can meet a patient where they're at and what fits their lifestyle. Dosages can range from as low as 2 or even 1 milligram. It's really hard to split that. So sometimes a solution is better if you're going below 2 milligrams. But generally, most persons where we're looking at treating aggression in the autism spectrum is around 5. Rarely do I see 15. If it's higher than 15, that's concerning. The benefit, again, FDA approved for reducing irritability, meaning aggression, tantrums, meltdowns in persons with autism. Doesn't make it go away, but can it make it less frequent? Can it make their quality of life better, their family's life better, school life better? Side effects, nothing ventured, nothing gained. So it comes with the trade-offs of somnolence or sedation. So you can dose it at night to maybe make the daytime a bit easier. If they're on too much, it can cause agitation, or even low doses can cause agitation, headache, and again, you'll see a theme, increased appetite. Atypical antipsychotics throw the appetite up in gear. It's just how the circuitry works, and it's so unfortunate. But with that increased appetite, typically that comes with weight gain, which comes metabolic syndrome, high blood sugar, elevated cholesterol and lipids, weight gain. Similar to Risperdal, the more risky or severe side effects can be drug-induced leukopenia or neutropenia, where the blood counts drop, can lower seizure threshold, and it can also, again, it can raise prolactin, but it's not as profound in Risperdal. Abilify, it's less than Risperdal. So perhaps if a patient had really severe prolactinemia, they could consider Abilify. It's not as strong with that for just the mechanisms of how it works. Monitoring, very similar to Risperdal, EKG, monitor the weight closely. Again, monitor for elevated prolactin. You can get prolactin levels. And again, very high dosages, you've got to be concerned about NMS, tardive dyskinesia, and extrapyramidal symptoms. So a take-home message with this, Risperidone and Abilify have the strongest evidence for severe irritability in autism spectrum disorders. The usual first-line medications are these when behavioral interventions are insufficient and the risk to the child and others is high. So behavioral interventions are always first and always need to stick with medicines, but it's reasonable to consider if it's going to improve quality of life or even give safety to a person and others. So now it is time for Q&A. Can you, I'm not,
Oh,
hi, I hear y'all now.
hi. Thank you for sharing, by the way. I just have a question for you about the recent information that came out from, let's see here. I know the American Heart Association had released something on melatonin, and they reported like an 89% higher risk hazard of incident to heart failure, threefold in HF-related hospital, and doubling of all-cause mortality over 5 years. I don't know what all that means, but it did make it did help me my ears perk up and wonder. In our family, I use melatonin consistently, and so just curious what you have read about that and your thoughts. Thank you.
Yes, so I was debating whether to include that or not, but clearly I should have. So yes, I've heard about it and read about it. it should give us more pause. It really it makes me concerned at how readily available melatonin is over the counter. Given that information, it should really be a higher threshold to take it and to take something that's perhaps less risky given that new information we have. That said, if I have a patient that's tried a lot of things or is scared of the risk of other things and they want to be on melatonin, life is short. There are so many risks and challenges and things we face. If sometimes it's worth that risk, if that is what works. So I wish I had a good answer, but I think that literature, the take home message is have more pause. I would strongly consider not using over the counters. It should be under physician guidance. And how important, how life changing is this medicine to quality of life? And if it isn't that important or you haven't tried others, I think it's reasonable to just give it more pause and have a higher threshold before taking this long term. I hope that answered your question.
Thank you. That's all the questions we have. Thank you so much, Dr. Worsham. I almost called you by first name because, yes, but thank you.
It's okay. Well, thank you guys so much for your time and have a wonderful time down there in Texas.
Thank you. Bye.